Hey everybody, I'm back with another video in this clinical toxicology series, and the topic this time is high-dose insulin, corresponding to Antidotes in Depth Chapter A21 in Goldfrank's Toxicologic Emergencies. The learning objectives are that you should be able to explain the mechanism of how high-dose insulin can be used to treat serious cardiotoxicity from calcium channel or beta blocker poisoning, and to outline a dosing regimen. Oh, and that figure in the lower right shows part of the quaternary structure of insulin. Each insulin molecule consists of two peptide chains connected by disulfide bridges, but these can associate with one another, first forming dimers, and then three of the dimers forming a hexamer. Two hexamers can form a dodecamer, but that's not shown here. This doesn't have anything to do specifically with antidotal high-dose insulin, but I thought this figure was just too visually appealing to not include somewhere. So let's discuss how it is that insulin can be antidotal for anything other than hyperglycemia. Normally, in a non-stressed state, the cardiac myocytes are highly reliant on fatty acid metabolism as an energy source. However, when under the stress of significant cardiac drug toxicity, say from beta blockers or calcium channel blockers, their metabolism shifts to rely much more heavily on carbohydrates, on glucose metabolism. And this situation is particularly compounded with calcium channel blocker toxicity. Normally, it's calcium influx into pancreatic beta islet cells that triggers release of insulin from the vesicles where it's stored. But if the L-type calcium channels are blocked, less insulin will be released. And this explains why hyperglycemia can often be seen with calcium channel blocker overdose. But while the serum glucose levels may now be elevated, it's only because the glucose isn't getting into the cells, where now it's needed more than ever because the heart is more reliant on carbohydrate metabolism, resulting in decreased inotropy and poor tissue perfusion. Basically, shock. If we now give insulin, it stimulates the cells to move more glucose transporters to their surface, promoting glucose entry into the cells. So insulin is the superhero, helping to get the glucose where it needs to be, correcting the energy crisis, which improves cardiac contractility and also tissue perfusion. Now, the insulin dosing needed to provide this kind of inotropic support is very high, which is why it's called high-dose insulin, or sometimes HIET, HEAT, standing for hyperinsulinemia euglycemia therapy. Treatment starts with an insulin bolus of 1 unit per kilogram, which is about 10 times the dose of insulin we might give initially to treat diabetic ketoacidosis. But since these patients might already be hyperglycemic, we don't always need to give dextrose along with the bolus insulin. If the glucose levels are below 300 milligrams per deciliter, then 0.5 grams per kilogram dextrose is given. Then the patient is started on a high-dose insulin IV infusion, starting at 1 unit per kilogram per hour and titrating up as needed, if we're seeing beneficial effect, up to 10 units per kilogram per hour or maybe even higher. The patient is also given an infusion of dextrose at 0.5 grams per kilogram per hour if needed to avoid hypoglycemia, that is, to maintain euglycemia. These patients are all going to the ICU anyway, but they're going to need frequent glucose checks, potassium monitoring, continuous hemodynamic monitoring, etc. The goal glucose level is 100 to 250 milligrams per deciliter. If the glucose level dips, you adjust the dextrose rather than decreasing the insulin, since we're needing the insulin for its inotropic effect. So now you know why it's called high-dose insulin, because the rates will be several dozens or even hundreds of units of insulin per hour. This is going to require close coordination and communication between the pharmacy, nursing staff, and the ordering physicians, since it's so far out of the ordinary. There are more details about dosing in the textbook chapter, in particular about how and when you taper off the insulin, and you can check this out if and when you're interested. But for now, we've basically finished. I'll be seeing you around.